Good morning. I'd like to thank the organizing committee for inviting me to present here, and I'd like to thank both of you for coming to this talk. We're going to talk about individualized lifetime risk in kidney donors and sort of build the argument for a new paradigm for evaluating donor candidacy. I have no financial relationships to disclose related to this. I would like to acknowledge the KDIGO work group. This was something that I was really enjoyed being a part of, and acknowledge our leadership, Crystal Entine and Amit Garg, as well as the CKD PROGNOSIS Consortium out of Johns Hopkins, in particular my mentee Morgan Grams and my colleague and mentor Joe Koresh for their involvement in a lot of what I'll present. I'll start by motivating the case for better understanding donor risk by quoting Joe Murray in his Nobel lecture, where he said that for the first time in medical history, a normal, healthy person was to be subjected to a major surgical operation not for his own benefit. And arguably, donors have no direct medical benefit. They may benefit from the fact that now a loved one is no longer sick. And so the concept of allowing healthy people to take risk goes from risk-benefit, which is what we usually talk about in surgery, to risk awareness. This is from a review article that Crystal Entine and I just wrote that'll show up in JSON, and you can get more details about it there. But you can see sort of the different perspectives of understanding risk in live kidney donors. And you know, sort of the old school way of doing things was to just describe events in donor cohorts. And that's very important because then we can say, if you're a donor, this is what the risks that you might face. And we could take that the next step and sort of compare between donor cohorts. So we can say African American donors have higher risks of ESRD than Caucasian donors or something like that. There were some comparisons made between live kidney donors and the general population. In fact, when I was trained on how to counsel donors, I was trained that you say, well, your risk of ESRD is no higher than it would be than the risk in the general population. But that's kind of a weird thing because the general population is obese and hypertensive and has other comorbidities, and donors are very highly selected. So most recently, there's been a lot of work done on the healthy non-donor. And what we mean is we mean people who didn't donate but could have been cleared to donate and how they did compared to how donors do. And then when you can compare, when you can have healthy non-donors and enough to study, then you can look at three different sort of escalations of risk. One is baseline risk. So your baseline risk is the risk that you would get ESRD if you didn't donate. Then the attributable risk is the extra risk beyond your baseline that comes with donating, and then they sum to what we call the absolute post-donation risk, or the total risk, and that's the risk that a donor would have. And so we can learn baseline risk from cohorts of healthy non-donors, we can learn absolute risk from cohorts of donors, and then we can estimate attributable risk as the difference between those two. And that's what we'll talk mostly about today. The problem with studying the major outcomes of kidney donation, i.e. death and ESRD, is that these are rare events. It's good that they're rare events, otherwise we shouldn't let people do this, but it's important to estimate these nonetheless. The problem is it requires thousands of donors to see one event. So even if you have a very busy transplant program and you study your last 600 donors, it's highly unlikely that even one of them developed ESRD, let alone enough that you can estimate the risk with any degree of confidence. For that, you really need tens of thousands of donors, especially to make subgroup estimates. You also need a non-self-reported source because it's very difficult. Some centers have managed to do this quite well, but even centers who do this well, to get 20-year follow-up on donors means that you have to have constant communication with those donors. And you know, once people donate, they go off and enjoy their lives, and they're not going to stay in communication with transplant centers. So it's good to have non-self-reported sources, and you want representation across low volume centers, high volume centers, centers who see patients with different demographics, et cetera. In the US, we've drawn a lot of inference from the OPTN live donor registry. Basically, since 1988, we've collected data on every single person who donated a kidney, and now there are over 120,000 people in this registry. So it's massive and it's unbiased, which means it's not just donors who have agreed to participate in research studies or something like that. It's every single person who donated, which is important to remove the biases from scientific analysis. The disadvantage is that in terms of studying outcomes, it's actually entirely useless because we have no long-term outcomes in this registry. However, we have identifiers since 1994, including the donor social security number, to allow linkage studies. And these linkage studies let us take non-self-reported outcome sources. Particularly, Medicare in the United States knows every single person who's on dialysis, and so we can identify who developed kidney failure. And the Social Security Death Master File knows every single person who's alive or dead, and so we can look at mortality as well. So we don't actually even need to have any contact with any of these 120,000 donors. We just need to link them to these data sources. In terms of finding healthy non-donors, a lot of work has been done recently using the National Health and Nutrition Evaluation Survey, NHANES. This was basically a survey of about 30,000 people where they did full history and physical, they did lab tests, etc. And from this, we can look at the charts and we can identify people who we would have let donate, so healthy non-donors. Unfortunately, this is a cross-sectional study, so there's no follow-up, but there is the same data for linkage in the same way that we link the OPTN. So now we have donors with ESRD and death outcomes, and we have healthy non-donors with ESRD and death outcomes, and we can do those studies. The first paper we published about 6 years ago looked at perioperative mortality, and what we were able to show is that 3 in 10,000 died within 90 days of donating a kidney, and we were able to make estimates based on age or sex or race, and that's kind of helpful, and it shows how extremely low that event is. We also followed live donors for 12 years and their matched controls for 12 years. And you see here that the death rate in live donors is actually slightly lower than in matched controls. But really the physiologic thing to conclude here is that whatever happens to the donors physiologically, they don't seem to have a higher premature death than non-donors, which is also a really important inference to make. But obviously ESRD, kidney disease, this is sort of the major area of interest and of concern. And we published a couple of years ago using exactly the linkage studies that I showed you that at 15 years, donors had 31 events per 10,000 of ESRD, while matched healthy non-donors only had 4, so an extra risk of about 27 per 10,000. This is very important to know. It's actually quite low, and so it gives us a good sense that it's relatively safe from a kidney disease standpoint. However, this is overall, this is all donors, and what we really want is we want patient-specific inferences. When we look at individualized risk prediction, typically what we do is we look at risk factors in isolation. So for example, in the United States, many centers will say the BMI cutoff is 30, or the BMI cutoff is 35, or something like that. What we lack evidence in, and this is what motivated this work, is the overall ESRD risk associated with the combination of risk factors that the donor brings to the table. Basically, we want a tool that says, for this age, this sex, this race, this BMI, etc., what is that individual's baseline risk of ESRD, and what is their attributable and absolute risk of ESRD. The problem is that while 120,000 donors may seem like a lot, given the rarity of these events, it's actually not enough for individualized risk prediction. And so what we did is we turned to the CKD Prognosis Consortium. Now, you think 120,000 donors is a lot. CKD-PC has millions of individuals from population-based cohorts, CKD cohorts, high-risk cohorts, et cetera. And we grouped all of this data together so that we could make baseline inferences from millions of people and then add on top of that what we know from actual donors. And we looked then at predictors like age, race, sex, GFR, albuminuria, BMI, hypertension, diabetes, et cetera, looking for a risk of ESRD. So what I'm going to show you now is all work on baseline risk. Now you may say, well, baseline risk, that's only part of the equation. A donor has baseline risk and attributable risk leading to absolute risk, as we talked about. And that's true, but the baseline risk is one of the most important things to understand, and we can understand it with more precision because we have more people who didn't donate than we have people who did donate. And then we can add on top of that the donor risk. One important inference from this, and this is kind of self-evident, but has not been part of the conversation until relatively recently, is that if you look at 15-year risk, you see that the youngest people have the lowest risk, and then it gets up a little bit as you get older, and then it comes back down a little bit, because if you're 70 and you're already super healthy, it's likely that you will stay super healthy because you've had 70 years of demonstrating that you're healthy. So here the risk is sort of equal over the ages and maybe higher in the older adults. However, if we look at lifetime risk, these are estimates of lifetime risk just stratified by age, you see that the youngest people have the highest lifetime risk. And here these are stratified by sex and race as well. But again, the point is that we should worry, and hopefully you do, more about the 20-year-old potential donor, even though they're completely healthy and that kidney is the most perfect kidney we'll ever get, then we should worry about the 60 or 70-year-old donor. The surgical risk is negligible in these patients, and the ESRD risk is actually the highest in the youngest people. So what we did with CKD-PC is we took all of these cohorts and we created what we called a base case. So the base case would have no hypertension, would have an age-adjusted eGFR, et cetera. And we wanted to say, based on race, sex, and age, what is the lifetime baseline risk for these individuals? And you'll see that if you are black and you live in the United States, and you're in your 20s, your lifetime risk of ESRD is 1.6%. If you're white and you're female and you're in your 60s, your lifetime risk is 0.14%. So less than 1/10 that of a 20-something-year-old black male. So this is base case. This is without any additional comorbidities. Now we can add things like decreased GFR. And you see that for black men, they start at about 1.5%, and their risk goes to about 5% if their GFR is 60. You see the same impact across the age spectrum. What is the impact of BMI? It turns out that at least with your baseline risk, the impact of BMI is actually not so high. So if we let a BMI 40, 60-year-old woman who has no other comorbidities donate a kidney, her lifetime risk is still about 0.2%, much lower than the lifetime risk of the absolute healthiest 30-year-old black man. We can look at the impact of smoking. We can look at the impact even of non-insulin dependent diabetes. So you might think, well, it's crazy to let somebody with diabetes donate a kidney. But again, the 60-year-old white woman with diabetes has a baseline risk of about 0.5%. The 30-year-old absolutely healthy black male has a baseline risk of over 1%. And so when we look at the entire picture, it's actually better to be a diabetic white woman in her 60s in terms of risk than a healthy black man in his 30s. You can put all this together. So these are, sort of, again, by single insult, but you can put all of the insults together on a website. This is a real active website. This was referred to in the New England Journal paper where all of this was published. And you can just enter all of the information about the donor, and it can give you your baseline, what we call pre-donation 15-year risk, and your pre-donation lifetime risk. I'll talk to you a little bit more about post-donation risk in a minute. So the way you can do this then is for your own transplant program, you can establish the risk that you're willing to accept, the baseline lifetime risk that you're willing to accept. You may say, we only accept donors whose baseline risk is less than 5%. And then you can estimate the individual risk for this person. You can sit down with them and show that to them. Post-donation risk is a little bit more tricky. We haven't yet finished the work on post-donation risk. You can assume it'll be somewhere about 5 to 10-fold higher than pre-donation risk, at least based on the work that's been published so far. This is kind of a big assumption. Hopefully we'll have more data for you in the next few months to better inform that. And so here's the acceptable risk framework. So the blue would be the baseline healthiest person. The pink then is the additional characteristics for that particular patient, so their BMI impact, their GFR impact, etc. So this is all baseline risk, and then the brown is the attributable risk. And we don't really know exactly yet how much more that attributable risk is compared to the baseline risk. And then we say, well, here's our threshold. We won't allow anything above this percent. So this person is out because their risk is above our threshold. But these two people are both in, and then we let the candidates decide, well, this is the lowest risk candidate. Maybe they're okay with it. This candidate, maybe we're okay with them, but maybe they say, well, I'm not the lowest risk, so I don't think that I feel comfortable with this. And so anything below this dashed threshold is for the patient to decide. Let's just look at the way some of these things can impact. So who in this room is more worried about a 20-year-old with these characteristics versus a 60-year-old? Who would more readily accept the 20-year-old? Who would more readily accept the 60-year-old? Right? And this works out in terms of the numbers. So it turns out that the 15-year risk for the 60-year-old is actually slightly higher, but the lifetime risk for the 20-year-old is the highest. It looks like with these characteristics, they're both very, very low. If you multiply by 5, notice I put 3 question marks here because we don't really know what the multiplier is. But if you multiply by 5, you see this, maybe we're looking at 3% lifetime risk after donation versus a 1% lifetime risk after donation. This is what happens if we now go from non-smokers to smokers, from an ACR of 4 to that of 10, from a BMI of 25 to that of 29. So more like kind of what people look like today. And then we start to get into sort of scarier numbers for these individuals, particularly for the 20-year-old versus the 60-year-old. In terms of hypertension, what are some of the recommendations for hypertension? Well, here's some from the Amsterdam Forum. Patients with a blood pressure 140/90 are generally not acceptable as donors. Some with easily controlled hypertension who are 50, GFR 80, etc., may represent a low-risk group and may be acceptable as donors. So a little bit of hand waving. There may be some things, but we're not exactly sure what they are. Well-controlled this is from the ERBP, well-controlled primary hypertension as assessed by blood pressure less than 130/85, under treatment with maximum 2 antihypertensive drugs is not considered a contraindication to live donation. Not very high rating in terms of data-based evidence. And so there's some recommendations for hypertension, but again, we can't make individualized predictions, but we can go to the calculator and do the same thing. So let's say 45-year-old white male with these other characteristics. How does going from a blood pressure of 120 to that of 150 affect them? Well, the pre-donation lifetime risk goes from 0.4% to 0.7%, still somewhat low. What if this 150 required antihypertensives? Now it goes to 1%. What if the person were black and not white? And again, this is US black, so African Americans. We see now their blood pressure 150 translates to 1.7% pre-donation baseline risk. If we do the 5-fold multiplier, then post-donation, now they're kind of in the scarier zone of about 9% risk. And this may be somebody that we would be more reluctant to allow to donate. This person we might let donate, but we might have to have a conversation with them about where their risk is. GFR the same way, the recommendation 80 or 2 standard deviations below normal, corrected for age, gender, et cetera, et cetera. Again, we can look at the impact of GFR on various characteristics of donors, donor 25 years old, donor 65 years old. You can see the impact on lifetime risk. With this person already, a GFR of 70 means a pretty high lifetime risk. BMI, we can do the same thing. Here's a recommendation to cut off at 35. Here's a recommendation to cut off at 30. In the US, in some places, if you cut off at 30, you wouldn't even have anyone come in the door. And this is the impact of BMI, and then here's the impact of BMI added to hypertension, et cetera. So you can go to the calculator, you can vary these things and see their impact. I won't get into the details. Again, albuminuria, you can do the same thing, and you can look at the impact of an elevated ACR on the various characteristics that your donor might have. Remember, this is only a meta-analysis of cohorts that were followed for 4 to 16 years. This is calibrated to the US, and so translating this outside of the US, you have to be a little bit careful, although a lot of the populations will probably resemble populations in other countries. And what's in the New England Journal paper is just baseline, and we need to either extrapolate post-donation or better study post-donation. So you notice in this calculator, the post-donation still have question marks. We're still working on this. We just presented at the ATC a study of about 130,000 actual donors, where we looked at the impact of various factors, like was the donor related to the recipient, and here's their 20 to 30-year risk of ESRD if they were related versus not related. What's the BMI? You see here that for a BMI of less than 30, they do very well, but for a BMI of 30, the impact rises. And what there might be is sort of a differential impact of BMI on baseline risk to the impact of BMI on attributable risk. We're still in the process of studying this. We can look at the hazard ratios of the various donor characteristics, again, adjusting for all of the phenotype of the donor. This is an important inference to make. This takes the distribution of predicted ESRD risk in the United States, and what you see is that most donors who have donated in the US were of a very low risk profile. But if you take the top 1% risk donors who we have allowed to donate, these are people who are in about the 3% risk. So 300 per 10,000, not 30 per 10,000 risk of getting ESRD. Bert Kosiski and his group, through the Alt-Olt study, have started to look more into granular details so we can learn more about GFR trajectories and things like that in donors versus non-donors, again, to try to understand this in smaller cohorts so that we can know more about the details of the donors. But we have yet to work out the post-donation risk, and the granularity that we have through KDIGO was the pre-donation risk. What are the implications of this? We currently allow individuals to donate who have a very wide risk range of ESRD risk. We currently decline potential donors who have conditions associated with a very wide range of ESRD risk. We currently accept donors, like the 25-year-old perfectly healthy black male, who have much higher risks than donors we decline, like the 60-year-old female with non-insulin-dependent diabetes. And we have a new risk paradigm driven by big data that will show up in the KDIGO guidelines and that hopefully will help all of us make these more complex decisions. So thank you.
We have time for a couple questions.
Shapiro Sinai, brilliant talk as always, Dory. There is obviously an element of paternalism in our refusing to accept people to be donors. and we live with that. Nobody's ever always spoken with the donors. And some donors may tell you that even if their risk is 3% over their lifetime of developing renal failure, they will happily take that risk to benefit their loved one.
Yeah, no, it's a great comment. And something that we will always struggle with is sort of the donor autonomy versus center non-maleficence obligation. And that's why sort of the new paradigm will say the center needs to decide what the center is comfortable with and to draw a threshold there. Anything below that threshold, then the donors get to decide. But obviously, you know, if a donor comes to us with one kidney and says, I would rather be on dialysis than my daughter, pretty much most people in this room would say, we have the obligation to be paternalistic in that case. The question is, if we can put real numbers on it, then we feel much more comfortable with where we can draw that threshold.
Last very quick question.
Yeah, very quickly. When you're comparing the 20 years old versus the 60 years old with non-insulin diabetes, the point is you are not considering the recipient. If the recipient is at 20 years old or 25, so you have to take that into consideration also in your calculations.
So I would agree that it is important, and we have the live donor KDPI paper that just got published in AJT that will allow somebody to understand how good of a live donor this person is for a particular recipient. However, I would disagree that when we evaluate donor candidacy, in our center, we split the donor and the recipient team, and I don't want to know anything about the recipient. I want to know, is this donor safe to donate? If the donor is safe to donate, then they can decide which donor do I want to use. If the donor is not safe to donate, then we exclude that donor and nobody can decide. So I think it's really important actually to separate the donor decision from the recipient decision. Although in direct response to your question, we actually have a calculator that lets you estimate the quality of the live donor.
Dory, one quick question from the chair. We're smack bang in the middle of Asia. Do you have enough Asian representation in the CKD prognosis consortium data and the US data to make implications?
Well, I would say we don't have enough, we don't have a lot of Asians from Asia in those cohorts, but when we've looked at Asians living at least in the United States and in the areas where these cohorts come from, the risk of Asians and the risk of Caucasians was pretty similar. And so for a lot of the studies, they've been grouped, and I think it's fairly safe to make those inferences, although again, there are differences across the world that will not be captured here.
Thank you.
Yeah, thanks.